still a little light on attendees yet. Give it another few minutes.
O'clock, and we'll wait a few more minutes. Some people may be coming in late from other meetings.
I just sent you a chat, Lynette.
Rose? One who is on, I want to give it a little bit more time because at the moment we don't have quorum for the meeting. So see if a few more people show up and then we can get started.
How many do we need, Lynette? Oh, you're muted.
Hear me? I'm talking. Can anyone hear me?
Now we can.
Okay. We need 6 for quorum, and we have quorum, so we are good to go. Happy Friday, everybody. Thank you for joining us for the Mental Health Parity Advisory Committee meeting. We have a robust agenda today, so we are going to jump right in. Before I take attendance, I do want to recognize that this is September. It is Suicide Prevention Awareness Month. And in celebration and commemoration of Jake's Law and the rules finally being finalized, and the people that were behind that with the heavy lift to do that, and for Jake's memory living on, I would ask that we take a few moments of silence just to commemorate this. Thank you. A heavy lift on everyone that was involved in that. So I'm going to start with taking roll. Carly Fleech, David Carnahan, Dr. Fowles.
I'm here. Good afternoon.
Good afternoon. Good to see you. Elizabeth Paz. Here receiving. Oh, she was on here.
She is, it looks like she's having trouble coming off mute.
Audio. She does it. Kathy is on as well.
Is that Kathy Busby I see a
I'm here.
Kathy. Oh, good.
I'm here.
Hi, Kathy.
Thank you.
Hello. Say
Monica
something
Curry?
on my phone. I'm out of town.
Okay, thank you. Dr. Wilson,
Good afternoon.
good afternoon. Vista
I'm here.
and Nicole Porter. The slide up, just remember a few housekeeping notes. This is a public meeting and it is recorded. It will be posted to our website after we get the video downloaded. Everyone has joined, knows how to mute and unmute themselves. And if you want to speak, just raise your hand or jump in. We are usually pretty informal, don't have any issues with people over talking to each other. So. The website has been up. It's been about a year, so it's probably time for a refresh, and wanted to solicit any comments, recommendations from the committee on what they feel, if they've looked at it recently, or if you want to think about it and come back for next meeting. Anything we should add, we should subtract. Any FAQs we should update now that the rules have been finalized. We'll be doing some additional stuff with that on our end. But anything that you can think of or want to suggest.
This is Carrie. I'll share that I recently, well, a couple months ago, did a presentation to all of our internal folks and some of our providers on, it was really just educating on Jake's Law and on the work that we're doing. And I put together a PowerPoint by kind of cutting and pasting together information and the FAQs and whatnot from the website. I just want to say I found them incredibly easy to follow. I mean, we definitely obviously can take a look and refresh anything, but I actually still felt like it was really well done, and it was very easy to have it make sense to people that weren't even connected, you know, to the work, or it applies to all audiences. The pamphlet in particular was really helpful to kind of cut and paste into a PowerPoint and have it be applicable and easy to understand for different audiences. I just offer that feedback.
That is fabulous to hear. Thank you so much, Carrie. We really appreciate that. We definitely want the website to be kind of a living resource. So, but I'm just tickled pink to hear that the information that was out there was useful. And our directive in Jake's Law, you might remember, was to have information that was readily digestible by, you know, consumers. So just really happy to hear that you found the information easy to read and easy to understand. So, but would love to have feedback from, you know, any of the constituencies involved in, you know, in these issues about how we can make it better, or additional information that we should include.
Anyone else? The next item is Jake's Law in the news. Wanted to know if anyone, since we did do a PSA from the department that the rules have been finalized, there is an article that has been published by another entity that we were made abreast of, and wanted to know if anyone else is hearing anything in the news about Jake's Law that they want to share. Good feedback, constructive feedback, indifferent, and does anyone have feelers out that they're hearing about how this is changing? Is it gaining momentum? Just curious to see what's out there in the community other than what we're hearing. No, nothing?
This is Carrie again. I can share that the mental health in schools and the efforts to increase access to behavioral schools is a significant conversation. Again, I know that I'm in this world. I, represent, a healthcare entity, Mercy Care, but we, in a lot of even in my own children's lives, and both my kids go to 2 different high schools, it's talked about a lot, and we see accessibility for mental health services and training. There's a lot around mental health first aid. Sometimes you see Jake's Law connected to it, but knowing the grant that's kind of that's behind it, it is very big in high schools right now on a personal level and on a professional level when we have schools outreaching us and asking us for partnerships with our behavioral health providers. So the messaging and the desires from schools to get connected to increasing mental health services is large. They may not have the words behind it, but I often know where they got it from or the kind of the string of dialogue. So I don't know if that's news, but the buzz, the conversations are very big in the community right now.
That's good. And I'm glad you brought that up. We do have some individuals from Access that are going to be talking about that specific topic with the children's access to care and things like that. So that's very timely. So we'll definitely be hearing from that in a few minutes. Anyone else? Definitely a good segue. Okay, next slide. So first is, let's see, is Josh on? Yes. Josh Stegmeyer from the Department of Health Services is going to give us an update on some things that are going on with him. He oversees the Suicide Mortality Review Program, and he's been working with the 988 crisis line. So Josh, if you're ready, we're ready for you.
Let me stop sharing the agenda and I'll switch over to the other presentation. Let's see here. Share the DHS, right? I'm sorry, let me, I'm having issues here. Okay. Can you guys see that?
Yes, we can.
All right. Thank you for getting that loaded. And I will go ahead and get started. Hello and good afternoon. My name is Joshua Stegemeyer, and I am the Suicide Prevention Program Manager over here at Department of Health Services. Happy Friday. Slide, please. All right. So I'm happy to provide a little bit of an update on those things that Department of Health Services suicide prevention team has been up to over the last couple of months. September's Suicide Prevention Month. We know this because Governor Doug Ducey signed the proclamation you're looking at in the center of the slide. This means that there is a month-long awareness campaign across Arizona and across the United States to bring attention to the problem of suicide in our communities. Some of the activities that we have lined up for the month are listed in the left-hand column. These include social media messaging on ADHS's Facebook and Twitter social media, several posts on the ADHS Director's blog, the Governor's Proclamation. We put together a Suicide Prevention Month partner toolkit and disseminated that out across to our stakeholders. And there's a 30-minute Suicide Prevention Month themed interview with Brad Snyder on his Talking About Kids podcast that will be available this coming Monday. And I really want to highlight some of the great work our media and marketing department have done to help us out with amplifying the messaging of this month. We have the world's smallest megaphone without their help. We've also developed a large network of stakeholders over the last year or so, and the right-hand column shows some of their activities. There are Out of Darkness walks throughout Arizona this month, and Out of Darkness is an initiative of the American Foundation for Suicide Prevention, and these are short, usually 5K walks to raise money for and bring awareness to suicide prevention. Also, the White Mountain Apache Behavioral Health Services are sponsoring the Life is Precious suicide prevention campaign, and they still have walks occurring on the 22nd and 29th of this month if you're looking to lace up your shoes. The Help Enrich African American Lives Coalition has held community events to raise awareness throughout the month, and Teen Lifeline held a large rally near the Tempe Market on World Suicide Prevention Day, September 10th. Several coalitions are hosting movie events this month. One I'd like to draw attention to is Bark for Schools is hosting an online screening of the movie My Ascension from the 18th to the 22nd of this month, which will feature an 1-hour Q&A with Emma Benoit, the cheerleader whose life experiences were the basis for the movie, as well as the founder of the Hope Squad on the 22nd between 6 and 7 p.m. There are too many events to list, but there are still events taking place in Phoenix, Tempe, Tucson, Prescott, Bullhead City, Lake Havasu City, all across the state. So plenty for you to get involved with. If you haven't done so already, please do. Slide, please. Switching gears a little bit from Suicide Prevention Month, I'd like to talk a little bit about 988 and provide a little bit of an update on that crisis line that launched in July. We're starting to see some of our first really rough preliminary data on the subject, and Arizona is performing above standard at every metric. I want to just highlight that because there were a lot of questions about 988 and a lot of nervousness before that line launched. And on this slide, I wanted to demonstrate how prepared Arizona was and why we are doing so well with 988. The blue bar in the graph represents calls to the National Suicide Prevention Line, and the dark red lines represent the volume of calls taken into the local crisis lines managed by the REBAs. So you can see there in the July numbers, that little blue bar had about a 50% increase of people calling into the National Lifeline. But that's still just a drop in the bucket compared to what Arizona is used to dealing with on the local lines managed by the REBAs. For instance, in May, the REBAs handled more calls than in July, and that was before the launch of 988, and they did so without a problem. So there was a lot of concern about how the system would perform, but we still have seen no indication that the service is struggling or slowing down within Arizona. Slide, please. There are two specific areas that I would like to call your attention to, and these data points found on the Tableau dashboard Solari is set up to provide information about the northern and central areas. Southern region data is a different contractor and isn't represented here. But one of the things I wanted to highlight was the referral sources. Many people are calling in for themselves, and that's that big blue bubble right there. However, the next three categories add up to a greater number than the self-referrals. Other refers to known persons like friends. And so that we see that friends, family, and behavioral health providers are calling this number on behalf of someone in crisis. And together they add up to more people than are calling for themselves. So that's an exciting trend. Another exciting trend is the number of police using this number, right? As opposed to another type of intervention that they might use. So the second point I wanted to highlight are the outcomes of calling 988. More than 70% of the time, 988 has recorded a stabilized outcome from a call. And that's really important. That's amazing. 70% of the time, they're able to handle it just between the crisis counselor and the caller. 21% of the time, the service's robust crisis mobile team intervention was dispatched. All right. 2/3 of the time of those instances, the team was able to resolve the problem, leading to a crisis transport only about in 7.5% of calls. The final outcome, the one that's sparking a lot of fear in certain areas of being hospitalized as a result of calling 988, that only happens about 0.2% of the time. This shows how successful the program has been at averting unnecessary ER visits and invasive police intervention. It has also been very successful in giving friends, family, and acquaintances new tools to help their loved ones. That's not everything going on with 988, but it's about all I have time to tell you with today. There's some exciting trends happening, and really good things are happening. A final note on this, our advertising campaign for 988 is still in line and ready to, at this point, be launched somewhere around the new year and hopefully last throughout 2023. And any changes to that, we'll be providing updates as we get closer.
Can I ask a question about 988?
Absolutely. We are just moving to the question and answer phase. If that's okay, we can go to slide. Yeah, absolutely.
Awesome. So I haven't tried it in a couple months, but when it came out, we tried it, and the guy who answered the phone was Jersey, and never heard of Solari, and so they stopped using it. And it's 211. So wanting to know what happened there. Is that resolved? Like,
Okay.
what are we doing when we call it?
Yeah, so this is an interesting problem that has to do with the national architecture around cell phones. And so, as you noted, it's the dialing code that got you to New Jersey. And the problem with this is that in order to route you more correctly, the FCC would have to enable Vibrant, who is the national contractor, access to more PII information around a caller's data than what they currently have access to. And so that is an ongoing discussion between Vibrant and the FCC, and we don't currently have a timeline on when that could be resolved. For people with an out-of-state area code, like myself, I'm 971 from Oregon, we've been promoting the local crisis lines to ensure that there is no lag time between when the phone is picked up and when you're actually talking to somebody inside Arizona who can connect you to services. I hope that answers the question, although it looks like CJ has some more information there.
Doesn't actually answer the question. I didn't think of that area, but that makes sense.
So this is CJ from Access. I apologize for joining late, everyone. There has been some national news, and we expect an update from Vibrant that the FCC is considering a negotiation of routing by cell tower for cell phones. So we can definitely get an update to this group, but until then, we are doing a lot of coordination work between centers in each state to try and get those calls transferred to the correct state once a person identifies where they're at.
Thank you so much for that clarification, CJ, and that's really great news. Thank you.
I just had a comment.
Hey, Josh. Hey, Josh, this is Rogers Wilson. Great overview. So one question, are we keeping from the Department of Health any breakdown demographics, gender, race, ethnicity, urban versus rural? Any background demographics for this data in relationship to referral and final disposition?
I'm going to give you the short answer that I don't know, with the long answer that ADHS runs the advertising campaign about this. But CJ, do you have any information that could answer that question?
Absolutely. Once the routing is a little bit better, we'll have much clearer data. Right now, we are asking our Lifeline centers here in Arizona to collect this data when it's made available, because callers are not required to identify themselves or their location. The data that they are collecting is not easy to really qualify, right? So the routing is going to help a lot with that. And then follow-up calls are definitely more successful. So as we get more and more people to agree to follow-up calls and actually access the services they're referred to, we can capture it there. So we are still working on how to not just gather data, but gather meaningful quality data.
Great. Hey, thank you.
Josh, this is Erin Klug from the department. I'll turn my camera back on. I'm just wondering, you had a slide early on that talked about the proclamation and some of the activities that DHS is undertaking to promote the campaign. I'm on your website, or I'm on your Twitter account now, which I am not skilled at all. But I think our agency would be happy to kind of retweet messages that you or Access are that either of your agencies are promoting around suicide awareness and around 988. So I'm wondering if I could get my PIO in touch with your PIO to make sure that we're able to do that. Like I said, I can see the I can't find anything on your Twitter account, but I'm sure that is my ineptitude, not not because it's not there.
Well, and that could be a better question for the PIO, Aaron. If you're looking for which one, we work with Steve Elliott and Tom Herman. If you want to have your PIO reach out to them.
Yep.
But we do have a list of messaging by day that they'd be able to coordinate with you.
Awesome. That would be great. Yeah, because I would love, at the last advisory committee meeting, it was either the last one or the one before that. There was somebody had raised the issue of 988 and should the department be promoting that a little bit. And we kind of got the sense that it was a little bit early days. But since Access and DHS are really starting to get information out there, I think it makes sense for us to just kind of push the information that you guys are already releasing on this topic. So, so I wrote down Steve Elliott and Tom Herman. Was that right, Josh?
Right. That Herman is with 2 R's and 2 N's.
Thank you.
Aaron, this is CJ from Access. We also have a PIO that would be happy to partner with you, Heidi Capriati, and we can get you her.
Heidi.
Okay. And then there's also on the SAMHSA website, the SAMHSA 988 information, there's a partner toolkit that includes social media blasts that they're asking all of our partners to take a look at, and feel free to use and retweet or any different social media platforms that's available, and it's updated all the time. So we can try and just include you guys, make sure we get that looped out to everybody.
That would be great. Thank you very much.
This is Don Fowles. I had a comment, a couple questions. Josh, first off, that's great information. Definitely appreciate it. One question is, and these may be, look, there's a lot of good work going on right now, and these may be difficult to answer right now, maybe just food for thought more than anything. But one thing is, so once all these activities occur, how does one know further downstream that everything's okay with the person who called in? In other words, they may have a call, they may have an intervention, but a week or 2 or 3 down the road, is there any way to do it? It may be very difficult, but I did want to ask, because sometimes, there's a good intervention at a point in time, and then that that's where it stops.
Josh, I'm happy to take that one if you want.
Absolutely, CJ. Thank you.
Sure. So the way that Access has structured the implementation of 988 for our state, we've filtered it into our REBA crisis system, and there are requirements for follow-up within that to kind of check on a person. We do have a blind spot with commercial payers, and if that follow-up needs to happen weeks out. So we are working in our state on that, and we have several of our providers that are working up in Washington about working with commercial payers and different health plans to do some sort of a connection for that exact reason. At Access, our rebus are tracking people that re-enter, so unfamiliars, meaning like uneligible non-access members that are calling multiple times to try and figure out if we need to do a little bit extra on the front end if they return back into the crisis system, whether it's through the call center or 988 or a mobile team or even our crisis stabilization facilities. So there's a lot of concern with that, especially since Access doesn't cover the whole population, but anybody can access the crisis system. What do we do about those folks that we don't have connection to once the call's over? So we're still working on that.
Yeah, that's good. That's good though. I mean, Rome wasn't built in a day, that's for sure. And every little thing that can get done, because sometimes some good things will happen with a member, during a given week or period of time, and then everyone feels good about it and justifiably so. But then a month later, you read about a bad event, and that's the sort of thing that the other thing I wanted to ask, on the chart there, the table, the crisis transport and crisis team was mentioned. And is there anything beyond that? Like, when a mobile crisis is called out to a home or wherever they may go, is that where the data stops when they've gone, or does it look at what the crisis team actually did with them? Did they refer them to the hospital? Did they refer them somewhere else, or were they stabilized?
Within the REBA system, yeah, so our crisis mobile teams do. I do want to note that several cities, counties, and entities like fire departments and various things have stood up their own version of a crisis mobile team, and I can't speak to the data that they're collecting. But if one of the Access REBA system mobile teams interacts with a person, they do provide back the referral or the disposition is what we call it. And if that disposition includes one of our crisis stabilization units, we get additional information when they leave there of what the discharge plan and referral and disposition was.
Yeah, that's good. That's good. No, I'm pretty familiar. I guess the question in that data that was there, did that account for that, or did it just stop with the initial call? That may be tough to answer though. The comment I had was, it's interesting that one of the larger groups that called in were behavioral health providers. And that can be a good thing in that, they're doing that. But the question it raises is, if the behavioral health provider is seeing that member and it's their patient, are they calling into a crisis line to cover a crisis that they should be handling? And I know that goes on, but I think it's something for us as a system to be thinking about how, look, if you have a relationship with a member, and more often than not, you should be handling those difficult times, not punting to someone else, unless you feel totally unqualified to do so. But most of the time, someone who hasn't established a relationship is probably in the best position to deal with a crisis rather than call the 988 number. And maybe there's some extenuating circumstances, and there probably are, but it was a curious finding, frankly.
I can speak to that.
I had just to add to that, I thought that was interesting too, and we talked about this in another meeting I was in. How many of these calls or crisis lines because individuals are getting on a platform, these internet platforms, the BetterHelps and the Sounder Minds, and the provider is not local.
Right.
So they may be in Colorado, so they don't know the resources here. So then they're trying to connect that person locally with the 988 number. So
Yeah,
brought that up.
that's something to be thinking about too. I'm a big fan and advocate for telehealth, big time. But I got to tell you, when in that situation, when you're in, say Massachusetts, and you have an Arizona license, you're seeing someone in Arizona, and a crisis happens, that there's a potential gap there. And I guess calling 988 in that instance is probably as good as one can do. But it's one of those things over time. It'd be nice to address a little better way than we have so far.
I can
I'm
speak
wondering,
to a different situation as well where the provider would call. Being a former provider myself, this situation I ran into more than once, and that is where you have a client, for instance, I'm thinking of the client I worked with whose diagnosis was borderline personality disorder. And she would frequently use suicidality as an attention-getting
Yeah.
method. And so while I was happy to help her when we were in session, it became such a drain on my time that we worked on calling, the National Suicide Lifeline rather than calling me. And that way that empowered her to be able to do something, but also made sure I wasn't getting 5 calls a day. And so I can't speak to exactly why providers are referring clients like that. But I think that there are enough situations where it would be appropriate that could be reflected in those numbers.
Yeah, and that's a good point. And there, Josh, as you know, probably that's more therapeutic to create an arrangement like that rather than you picking up the phone every time she calls. And I think that's a better way to do it. I'm a little more, a little more concerned with those who say, "Hey, it's 5 o'clock. It's time for me to go home. I don't want to deal with this crisis." And, like it or not, that's what we signed up for. And that's the area that I think needs some attention, not now, but certainly some thought and some consideration about how we can address that a little more effectively.
This is Nicole. I'm not sure if we're the type of providers that you're referring to, but as a private practice psychiatry providers, we're equipped to manage patients in some sort of distress, but definitely not crisis. And so historically, we used 211 to get the crisis team out to get a patient to a crisis setting or a hospital, depending on how severe their crisis was. If they were to arrive at office in that severe crisis. Is that not how we should be using the 988 now?
this is CJ. I'll jump in there. 988 is designed to be used for any type of crisis, and as a practice, if that's what you feel is therapeutic, please refer. There's no wrong door when it comes to entering the crisis system. So even repeated calls, the system is designed to be there for anything. We want you to use 988 and our local crisis system as you've always used it. That's the whole plan at Access, is to just integrate this as another entry point. So I wouldn't say that redesigning any practice. The issue we do have is that routing, and to a lot of folks' point, it is concerning to have someone's in crisis contact a center that is not in Arizona, because not all of those states have our system. So we are still working with our partners, our providers, our REBAs, our state agency partners, to continue to promote the local access 10-digit numbers, REBA funded services. But any of them will come to us eventually. It's just how quickly we get them in contact with an Arizona center that we're trying to, let the system catch up to us.
Thank you. I'm still not sure I'm using it right, but that could be an offline conversation. I think we think of it as, this is how we get a crisis team out here. So this patient is in such crisis that they can't drive themselves to, like UPC or Aurora or something like that, and we can't drive them, and they're in our office, actively suicidal in crisis. And that's how we had used it in the past. But what I'm hearing makes me think that might not be how we should be using it.
So that is how you should be using it as a private practice for sure. But I would still strongly suggest you use our state lines because you won't have to wait. So as a system partner, you don't want to go through when you call 988. Interactive voice system answers, and there's about a minute and a half of making selections, and then you get routed to wherever you're routed. So to streamline that for you as a provider with someone actively in crisis, where you want a mobile team to come out and help transport this person to a higher level of care, like a stabilization facility, we certainly want you to access our crisis system, but we want you to do it through those local lines if you can. If you can't remember it, 988 will get you there. It's just the fastest route is to use those local numbers.
Thank you. That is what we found since 988 has come out, that we are having better luck just using our local numbers for that. So that does make sense.
This is a good segue, since you were going to speak on the crisis system, to jump into your presentation. I don't know if Ellie, you can pull CJ's. I don't know if we're separated or if we need to start with Dr. Megan first.
Let me end this presentation, stop sharing, and then switch to the next one. Let's see here.
If it's helpful, I'd be happy to allow CJ to do her crisis slides first, since it's kind of a good segue into her slides, and I'll finish it up with the Jake's Law information.
Sounds great.
Can you guys see that?
Yes.
Yes.
Yes, there's a few slides on Dr. Wood's presentation if you want to skip ahead to CJ, and then we can circle back to behavioral health and schools.
Do you know what page that is? I'm trying to.
Feel free to scroll through the first 3 or 4 and I'll let you know. There you are. There's CJ's. Thanks.
All right. I apologize. I wasn't on when Joshua got started, so I hope this isn't too duplicative. But I just want to kind of go over what 988 is, and I'm sure he probably covered this. So 988 is a new dialing code for the National Suicide Prevention Lifeline. It's been around since 2005. But in addition to just changing how you access that network, the additional national attention on our behavioral health crisis systems across everywhere, and our federal funding, we've been able to enhance that system to not just focus on suicide prevention, but also generalized crisis calls. So anything from, depression, anxiety, whether or not it's related to suicide, and even substance use disorder related crisis. I'm sorry, was someone trying to jump in? Okay, next slide. So the way that we've decided and worked towards integrating 988 calls into our existing REBA system is this is just a graphic of it, where we have asked by contract that our ACC REBAs that are taking over in October 1st this year, all 3 select one call vendor, and that vendor has been selected as Solari, who is also the primary 988 Lifeline administrator here in Arizona. What that means is I was talking about that streamline. So if you call a local REBA number or you call 988, you're still going to get into that Arizona-based call center, and that provides that access to the mobile team dispatch, referrals to local resources, including all of our 211 resources, because Solari also is our 211 vendor. Next slide. Just to give you guys a picture of our current REBA volume for our call centers, this demonstrates the vast number of calls that are really coming in through our local and established lines. We did anticipate in July that we'd see a spike in the blue, which represents those lifeline numbers. So up until July 16th, they were dialing that 1-800-273-TALK. And then as of July 16th, the 988, we saw a spike of about 1,000, a little over 1,000, but we also saw a spike in our local lines. So just the national attention reminding people that crisis services were available really speaks out there. The big concern and what we're monitoring this for here in Arizona is the primary users of our REBA crisis lines over the last few years are about 80% Medicaid eligible. And we fund this system with braided funding. Some of it's Medicaid. So if a Medicaid eligible member contacts, we can definitely draw down those federal funds. And then some are folks that have never engaged with the public health care system. And we have blending of grant funding and general state funds that can go to that. So we have to watch this very closely to make sure that those resources that are limited by as available, so grants, general fund, so on, are not exhausted. Next slide. So really, what is 988? I think we all kind of know this one, so I won't read through all of these, but if you want to go to the next slide, we talk about the 988 marketing with ADHS. I think Josh covered that. And then one more here. Go to the next slide. I want to talk about our 911 and 988. There's been a lot of misunderstanding of 988 possibly replacing 911, and we definitely want folks to use 911 when it's appropriate, or I'm sorry, 988 when it's appropriate, but keeping in mind that 911 is our emergency dispatch center, and 988 does not have lights and sirens on our mobile teams, things like that. So life-threatening emergencies will probably always route through 911. What we're doing here is trying to make sure that we're connecting the right response to the right call. So working closely to develop policies and protocols for 911 diversion. That's been our primary focus here. So working with those we have 81 PSAPs here in Arizona. Each of them have the authority to develop their own policies and protocols for dispatch. So we want to be known as their first tool, and 988 and 911 being their fourth tool, and 988 and 911 being best friends. So right now, my last check, and we haven't even got 100% of the PSAPs to fill out our tracker. We're at about 25% of those 81 PSAPs that have formal protocols in place to divert calls that are identified as behavioral health. We have Solari and all of our REBAs reaching out to the PSAPs and offering training to the dispatchers and the triage folks at all of those 81 dispatch centers on how to identify what is appropriate to be transferred directly and which calls we can collaborate on. So some of that looks like co-location, some looks like telephonic collaboration. And we've been working with ADOA. They've been able to, and I think I gave a resource link on here. You guys can look at it. ADOA has actually posted some draft tools for these PSAPs to adopt, including a policy template, decision tree, and so on. So very, very cool work going on there. So again, just want to reiterate, especially this group, we're not wanting to emphasize to never call 911 in a life-threatening emergency. We want people to use 988 when they feel it's appropriate, 911 if they feel that's appropriate, but we're working on the background to make sure that if they do contact through 988, they are very seamlessly transitioned into the behavioral health and system, and that they get the appropriate response to minimize law enforcement and EMS having to go out for behavioral health calls. We do have a 988 advisory committee at Access, and we meet monthly right now, and we'll be continuing to monitor this progress. Next slide. That's the end of mine. I believe this is Dana. Do we have any questions on that stuff? I know I went through it pretty quickly.
Just a comment, and that is great information. I think it's really good that Solari's been leveraged and used in the way they are, because they do a great job. And I think we're very fortunate to have resources like we have. One, honestly, we have one of the better crisis systems in the country in Arizona, and it sounds like it's only getting better.
Yeah, we are the more interaction I have with other states, the more I'm very grateful to have my career based here in Arizona. But it is really cool to watch the rest of the nation trying to catch up. And we're learning from them as well as people are building new systems and coming up against new ideas. It's really impacting us as well. So it's been great, but we are very fortunate here in Arizona.
Yeah,
Correct.
Indeed.
CJ, this is Erin from the Department of Insurance and Financial Institutions. I guess I just wondered the difference between the Lifeline number and the 988 number. It sounds like that local number is going to persist. And I know as somebody who's only, on the outside looking in to the system, I'm still not clear on, I heard you say very clearly there is no wrong door, so if you're not sure, just call 988. But it sounded like there were also circumstances where calling the local number might get you faster, might get you more quickly connected with the people that you need to talk to. Are there materials that kind of spell that out? Are those messages that we should be trying to help communicate, or is it better to just say no wrong door 988 if you don't know?
Yeah, well, we really want to support the evolution of 988 as a nation. And so it's been very difficult to develop materials that say, but if you're in Arizona, call these local lines because they work better, right? Because we're trying to support the national movement. So as we're working with our partners, our system partners, schools, public safety answering points, law enforcement, we're definitely asking, use those local numbers. We're going to maintain those. You can see by the slide that showed the volume, we're definitely not going to take something away that's being utilized that heavily, right? So yeah, I mean, none of them are going to be a wrong door, but individual, like our providers, our law enforcement, all of our partners, definitely, if you have the time to look at what is the local number for you here in Arizona, please continue to use it as 911 grows. But we do not want to discourage anybody in the public who could easily remember 911 in a crisis from calling 988. You know what I mean? 988 in a crisis. So there are no printed materials right now that say 988 is great, but use us for that reason.
Okay. That makes a lot of sense. Thank you.
Yeah, so CJ, so I know on our website and as well as our community brochure, we do have the local crisis number, and we will update that to add 988 as well. So we could just, with the verbiage, you can call 988 or your local number, just so that they have both options, correct?
Absolutely.
We're not trying to alienate the 988, but still want to encourage the local in some way.
Yeah, and our website is going to continue to reflect that exactly. Dr. Hennigan, we'll be making sure that we maintain the local Arizona line, and then also promoting 988. Again, lots of folks, our crisis line numbers have been around for so many years in Arizona. Lots of folks have those in their phones. They have magnets on their refrigerators. There's no reason to get rid of all of those resources for folks that are already used to using it, but we do want to promote that there is no wrong door. And, I hope that as we work more with SAMHSA, we can minimize that delay in the amount of time it takes to go through those menu options. We've talked about possibly doing a skip this in an emergency, or making number one just be transferred to your local, and then ask them if they want the VA or if they want Spanish speaker. So we're brainstorming that, and hopefully we can make that as streamlined, because as we move along and the system evolves, we definitely know that 988 is easier to remember than any 10-digit number that we can put out there. So we do anticipate a cultural shift, and we want to make sure that that shift doesn't have a negative impact on the system that we've built here.
So Lynette, to your point, I just put a link in the chat specifically to our community brochure. And you're right, it has all the local lifeline numbers. So my question for this group is, should we, and it also has 211 on it. So at a minimum, we should be adding 988 to this, but I guess I'm just wondering if there should be some little sentence in there that says, mental health providers should, I don't know what the appropriate message would be. So I mean, maybe CJ could take a look at our brochure and see if you have any suggestions about how we appropriately reference the resources for folks on our brochure. Would you mind doing that?
Absolutely. And I'll also partner with Heidi and see if our PIOs are putting anything similar together, share that resource with you guys. But I'd be happy to look at anything that you have now and offer any input.
And thank you so much.
And Aaron and CJ, we had provided this committee early on our crisis website, which I dropped in the chat as well, which references all of the above, Aaron. So hopefully that will be helpful as well as how we're messaging the 988 opportunity as well as all of our local lines. And so hopefully you'll find that helpful as well.
I don't see what you put in chat, Dana. I'm looking.
It's showing on my end. It dropped at 12:39 and it just says for local numbers and it gives you the Access website, behavioral health and crisis, but happy to send over.
It didn't come to everybody.
Oh, okay. It says all attendees. I don't know.
I don't know. Is
Attendees
everybody
are
else
Send
different.
it over.
Attendees
Okay,
are
thank you.
public members. So I don't know if that.
Oh, I don't know. Yeah, but Dana, if you could just message that link to Lynette and I, then we can make sure that have them. Thank you.
We'll send out another update in a couple of weeks. As our contracts change this year, we're going to have a single statewide number that's going to replace those three. We'll make sure you guys get that as well. And then we also on our website have the local tribes that have their own dedicated lines. So encourage you guys to take a look at that and see if it's appropriate for your material so that our tribal folks are getting connected to their own lines when they choose to do that.
That's really important because this brochure is specifically was intended to hopefully help folks in more rural areas in particular. So that's a really good point. Thank you.
No problem.
Any other questions or comments for CJ?
Great stuff. Really good stuff. It's good to see.
Or Dr. Woods? I don't know who wants to jump in first. Let's have the floor.
Thank you. I will try and go quickly through my information. I think a lot of the participants here are pretty familiar with Jake's Law, so we can skip some of that overview. But Jake's Law is just one component of the services that we have really tailored to ensure that we're providing behavioral health services in any community location as the result of a referral from a school or even on school campuses where there are direct agreements between schools and providers to make that happen. We also cover, as we were just talking about, crisis services for all Arizona children. We've expanded pretty significantly our Medicaid school-based claiming program, and we continue to work on that through not only our Division of Fee-for-Service Management, but also with a partnership that we have directly with Department of Education managing 2 grants that we have from SAMHSA under Project Aware. And then we coordinate with our Division of Grants Administration for grant-funded behavioral health services for those children that may have a serious emotional disturbance and qualify for funding under the mental health block grants or for our services funded under the substance abuse block grants. So just wanted to make sure that we get a lot of people excited about all of the various ways that we can fund the behavioral health services for these children throughout the state. You can go to the next slide, please. So specifically what we have been working on over the last several years is just really trying to expand the education of community providers and schools about how to build those relationships so that we can partner together to offer services either, like I said, either on a school campus or through a referral from any school, private school, charter school, or public school. We have really encouraged all of those schools in the state through presenting just about anywhere they'll allow us, make the referral. There is no wrong door. We will figure out how to fund those services for that child dependent upon their eligibility, either through one of our Medicaid health plans or through the block grants, Medicaid school-based claiming, et cetera. We really were coming up initially against a lot of barriers where the schools were trying to battle through FERPA to find the way to determine eligibility before making the referral. And so this has been kind of a switch for all of our schools to just send in the referral and we'll figure it out from, you know, the Medicaid eligibility perspective. With the programs that we are currently trying to stand up, we are trying to be really creative in lieu of some of the staffing shortages that we've seen since the public health emergency, where we are offering various ways to support the staff at the school to provide the services under Medicaid school-based claiming, or if they're not qualified under our Medicaid school-based claiming program, that we can offer to have those staff enter into contractual agreements for supervision services so that they can offer services in partnership maybe with one of the behavioral health agencies that is in agreement with one of those schools. You can go to the next slide. So for Jake's Law, there has been, as Dr. Hannigan mentioned, some interest lately in the media about Jake's Law and our implementation of that funding. We have been really encouraged just that we've been able to get this funding out for the amount of students that we have. To date, it's been just under 1,000 kids that have been able to receive services. The good news about that I don't think was kind of highlighted quite as well as it maybe needed to be is that we've done a tremendous job of finding these kids ongoing sustainable funding for behavioral health services as much as possible, in many cases making them eligible under Medicaid funding or being able to fund them under one of the block grants so that there is no concern about the ongoing funding for whatever necessary services there may be. We have had a couple of years now of tracking of total behavioral health service referrals. So just in the month of July 2022 through August 31st, 2022, we had a total of 1,260 referrals for behavioral health services for students. I think that's tremendous for the first month coming back to school from summer vacation. Out of that 1,260 referrals, we were able to find alternative funding for nearly all of them so that we only had to serve 133 kids under the Children's Behavioral Health Services Fund. So that to me is a bit of good news. I think that it was maybe reflected in more of a negative sense recently, but it's actually really hope inspiring that we do have available funding for these kids for many of these services. We continue to work with all of our REBAs to find additional behavioral health partners that can deliver services in some of the more rural areas of the state. We've done some really exciting work on Tohono O'odham recently, bringing in new partner agencies and helping with the provision of services out in a very, very far area of the state where there's historically not been a ton of service availability, and partnering with new provider agencies and bringing in telemedicine has been a really great way that we've been able to provide counseling services, offer skills training services, and even parental support for parents that are requesting to receive more of that training for themselves and working with their child. The only other thing that I think I would mention is that we do currently have 788 schools that have been submitting referrals under any type of behavioral health referral for any type of service from a school. The schools that are able to submit referrals under Jake's Law must meet specific requirements for having policy that has been publicly vetted, so allowing for a public comment period. And they must also adhere to the remainder of the law about publishing what their policy is on their website and what available providers there are. And then we do offer a survey. It's not required for any participants under the block grant, under Jake's Law. It's not required for them to participate in that survey, but we do offer that to receive feedback on their satisfaction with the entire process as well as with their service delivery. And our first report will be this December back to the governor's office on those survey results, although the majority has been very favorable for those services that have been received. I believe that is my last slide, and we are a couple of minutes over, which I apologize for, but I tried to speak quickly and hopefully not too quickly.
Megan, what's that? I think you said 788 schools have submitted referrals. Did I hear that number right? In Arizona?
Correct. 788 schools. That is just from the period of June 1st of 2021 through July 31st of 2022. So that doesn't have the data from July through August. So there may be more by now. We've been working with the Arizona School Board Association to publish a template policy. We had worked on here at Access with them and with all of our ADE partners, and so many other community stakeholders were helpful in developing that policy template so that it was really easy for schools to come and come into compliance with the requirements of the law.
That was my next question. Is there a list of those schools? If the public wanted to know whether or not their school was one that had the ability to make referrals, is there some way for the public to find out if their children's school is eligible or meets the
So we
criteria?
have not published that listing. I have a little bit of hesitance to make that a public listing, only for the reason that by publishing a list of schools that are, quote, able to make a referral, it would then infer that there are schools that are not able to. Any school would be able to make the referral. They would just need to follow the requirements of the law in order to make a referral that counts under Jake's law.
Gotcha. So what again, being not embedded in all of this myself, if I was a parent with a child in school, how would I start the process? How would I go about trying to make sure that I was talking to the right person at the school to be able to get services for my child?
Yeah, great question. We've tried to do a really thorough job, and there's never enough, right? So we've tried to do a lot of community education. We have 2 staff that are co-owned staff. I'm using air quotes. My camera, for some reason, is not wanting to show me just my background. At least I don't think it's showing me. Maybe it is. We've tried to do a lot of education that there are no restrictions to a family talking to a teacher and making a request for services, or a teacher making a referral directly. We actually have some plans that we are targeting some new Project Aware 3 grant funding on developing a pathway for referrals to come in a pretty blind way. So it could be a teacher, it could be the cafeteria worker, it could be a school janitor, I suppose, that could kind of say, like, I've noticed these behaviors with this student. They may need to receive services. And through that process, we would be able to utilize the staff at the school, as well as partnerships with ADE to vet those comments or kind of triage them for whether a referral would really be necessary to a behavioral health service provider. I think that there's probably some additional work that we could do to get beyond just a school counselor has to be the person that makes that referral, because that's really limiting. And for schools that don't have a dedicated school counselor, there is no other pathway. So we have to be able to get beyond that kind of thought process.
Dr. Megan, also 2 questions. Is there, oddly, I've had a few phone calls this week, just parents trying to get services for their children, and I'd let them know about this. But again, their school is telling them that there's not funding, or it sounds like it's very dismissive when they explain it to me. So I don't know if there is like an ombudsman number they can reach out to Access to say, I'm trying to get services for my child. The school is telling me there's not funding for services, which I know is not true. Or so that's the first part of the question. Or do you go out to school boards and do presentations, or PTAs? Because I feel like some schools may be either afraid or they want to do the law piece of it. I don't know what the disconnect is.
Yeah.
But just making sure I know there's funding. So not for a school to tell a parent there's not funding for their child to get counseling and to go back to their primary care provider just seems very dismissive to me.
Yeah, and Dr. Hannigan, that's something that's so interesting about the way that this funding is. And I actually talked to Jake's mom, Denise, about this as well, that when the law was originally written, perhaps we did not understand all of the nuance that exists with these school-based referrals. It sounds like such an easy thing because kids are at these schools 8 hours a day. But really, it's not as easy as it sounds. With all of the school districts having local authority, there is no kind of authority that ADE has to require every single school in every single district to come and learn about this funding and how to get kids connected. So the beauty is that even if they're referred back to their primary care physician, with the amount of kids that we've seen get referred that we can find alternative funding for, even if they received a referral through their primary care physician, we could likely find a way to fund them outside of even Jake's Law. Now, that doesn't mean that we're not continuing to work really hard to get the word out to every single school. With our 2 Project Aware positions that we have here at Access, we do have them working with the Project Aware school districts, but also taking that information statewide as much as possible, presenting at every single educational conference that is offered here in Arizona. And then we also have our health plan partners, so Carrie's on the line as well. They have been doing a tremendous amount of work. They all, at each one of the REBAs, have a dedicated staff person that's working on school-related behavioral health services and trying to connect to provider organizations and help them to navigate through those relationships with the schools. It's just that there's not enough of us to get to every single school, and it would be great if we could, and we'll go anywhere you want to present this information where we can get the word out even more.
Anyone with any other questions for Dr. Woods?
Lynn, I just want to say this is extraordinary work. This is a lot, as Megan said, it's a lot tougher than any of us probably can fathom. And the efforts y'all have taken have been really amazing and extraordinary. There's no other word I can think for it. And just keep up the good work, because the kids really need it.
Thank you. That makes me warm and fuzzy inside. I will say, one of the things, I never thought that I would be able to say that this is a positive, right? So last week, there was an incident that had occurred at a school that triggered a lockdown, and 3 or 4 community schools surrounding that one school all also went into lockdown. We were able to reach back out. Mercy Care, tremendous partner, able to get behavioral health providers immediately in touch with the individuals at those schools to offer behavioral health supports and services for anybody that may need it, because that's a really traumatic event. Even though nothing actually ended up, happening, there were no students harmed, no staff harmed. Still, we were able to get out that we can provide supports to anybody that may need it, because this is really scary in this current environment. That in and of itself, with the school locked down, is very scary for parents and for the students. So it's been awesome to see how that has played out in our ability to immediately respond when something like that happens.
Bravo.
Yeah, really.
And you're right. It's scary times, and just as a parent, I was sharing this with Erin. I have a 10-year-old, and she's already, the stuff that they're talking about at school, that as far as mental health and behavioral issues, just blows my mind. That at 10, this is what conversation is in a lunchroom, and bullying and telling people to go kill themselves, and it's just mind blowing. So
Yeah.
this is a fantastic resource, and I'm glad it's there.
Yeah, it's something else. I think one of the things too that I really appreciate, Megan, is that there's no stopping you. There's you're going to try whatever you can whenever you can, and it's just a never say never type of attitude, and it really helps a lot. It just keeps the thing going. One thing I did want to say just real quick is COPA is actually sponsoring an event in November 5th in Mesa, and anyone interested can get more. But it's a guy, Alex Boyer, who attempted suicide himself. He's from Africa. He came to the States through New York, and his story is amazing. I've met him a couple of times. He's an amazing guy. But what he does, people get invited to these things, and kids and their families come to them, and kids will get up on stage and tell their story. He's an entertainer by heart, by nature, and he's great at what he does, and he's got a band and all sorts of entertainers. But they get the kids up on stage with their families. Everyone has a good time, and you also hear stories of people who've been through some tough things, and he'll get 5, 7, 8,000 people at these things. And so it's just one more of those little things that we do in our community to try to move the needle forward a little bit more. because this is, look, Access does a wonderful job in the plans and providers, but this is a community problem. It's our problem, and it takes things like this to do so. Anyone interested, we can certainly provide more information, but he's an amazing guy. Alex has been through hell and back. I don't know how else to say it, and he's come out the other side with a very optimistic, positive message.
Dr. Fowles, if you want
Dr.
to put a
Fowles,
link to the event in the chat, feel free.
Yeah, I'll try to figure out to get to you.
Sorry.
Or if you email it to me, I can blast it out in an email.
Yeah. Okay. Good. I'll okay. Great. That sounds good.
Perfect.
This is Carrie. I was just going to add something to something that Dr. Fouts said and Dr. Woods, and I do think that that we're in a really critical, but and this is going to sound odd, but exciting time in Arizona, where we do have the leadership from Access, the health plans involvements, the schools, and the community, which it really does take all of us. When you hear that, it takes a village, this is one where it does, because each school is its own little entity within itself. And so it really does take us on a personal level and on a professional level wherever we're at. And that I do think that the opportunity and the availability of services and the want to provide services is at an all-time level. The conversations that schools are having are unbelievable. Like I said, I shared I have two kids in two teenagers in two different high schools, and they both are doing presentations and movies and nights where they're bringing folks together to talk about it. So it is an exciting time, and I say that because we have it kind of at all levels, and when we have the funding and the folks and services behind to support it, it's where we need to be, but it really does take everybody, and I just would reiterate that and thank everybody for your support and your work, kind of in the work that we're doing for this, and to Access for their leadership and, kind of that top down, going up and down both ways, from the family members that are advocating to all of us, that really it is taking all of us, but it is making a huge difference in communities and in kids and families' lives. So thank you, everyone.
Dana, are you ready for your section?
Sure, Lynette, but I also want to be respectful of time. I know we went well over our slotted time, so if I can do a 15 to 30 second pitch, I'll do that instead if you'd like.
15 to 30 seconds. You can have a whole 60 seconds if you.
Okay.
We'll make it work. We will make it work because I think what we've discussed has been meaningful and purposeful for what we're doing. So yes.
Sure. Yeah. So as you all know, we have a ton going on at Access. We've talked about two wonderful things, but just something that I take every single opportunity I have between now and especially what we predict to be January, the end of the public health emergency. We are serving 2.4 million Arizonans at this time. And we've talked a lot about the importance of services, but in order to get services, coverage is important. And so as we look at people that have coverage currently under Medicaid, the need right now to make sure your address is current so that Access can get a hold of you as we do our 12 months of unwinding process. Once the public health emergency ends, that's super, super important. So we have tons of resources on our website. So right at the top, it says COVID-19. You can click that and you can get a return to normal, end of the public health emergency. And just like we have a lot of resources, as CJ mentioned, for crisis and social media, we have the same thing for unwinding. So for all of you that have connections in the community, again, 2.4 million. So would love any help we can get on making sure to get the word out about that.
And if I'm just gonna echo Dana's comments there. As the state insurance body, we are hearing a lot about the PHE unwinding as well. And if there are messages that we can help promote, the messages that you're putting out there that we can help promote, we'd be happy to do that. We'd be happy to put information on our website. This isn't just about mental health, but it's just about people being able to keep coverage. So, or get the different coverage if they no longer qualify for Medicaid. So please don't hesitate to reach out to us, Dana, if you think that there are ways that we can partner to help get those messages out to folks as the PHE
Sure. Lynette, I'll send you the link to the kits that we have, as well as put Heidi on that email as well for any messaging that you all can assist in. I truly, truly appreciate it. It's going to take the whole community to make sure that this goes smoothly. But I will say, similar to crisis, as we talk about this across the country, we are way ahead as usual here in Arizona. And so I'm really hopeful that this will be a smooth transition out of the public health emergency.
I've actually heard CMS say that.
I have too.
So yes, bravo, yes. I've been in touch with Heidi about the PHE unwinding, and I'm familiar with their website. So I think I'm thinking more again about how our PIO can connect with your PIO. If you guys are doing messages through social media or press releases, if we can, kind of get those out through our chains of communication, we'd just like to kind of help you if we can.
Absolutely. Thank you so much for your partnership.
Oh, thank you.
Dana? Okay, Elian, can you go back to our agenda slide?
Okay, will do. Let me switch over.
Pulling that up, I know we have like minutes. As I mentioned at the beginning of the meeting, the rules have been finalized, and now is the heavy lift, and this is where we need a lot of input from the advisory committee. So we are now entering into implementation phase of the rules. And so as we start that process, we want to hear your feedback on which NQTL should we prioritize. As we get prepared for the reports to come in, it is not feasible there's tons of NQTLs. We can't say, just send us all. We want to be very strategic and very focused on which ones should we focus on first? Which ones do we believe are a priority to tackle first and to dig into first? So here are, we pulled 6 out, 7 if there's other suggestions. And if you don't have to give an answer right now, you don't have to rank them right now, but if you could even start thinking about that, like, or if one's not on the list that you want to recommend, like, really need to focus on this one first, or these 2 first. We'd love to hear your feedback, and so I wanted to open that up for discussion. I don't know if you have anything else to add, Erin, from about the list or the implementation.
No, I don't have anything to add. I think just that we would really welcome the different perspectives on the importance of these NQTLs and any other NQTLs that our various stakeholders think are worthy of the first look, the early look by the department. And maybe just a little bit of background, just as a reminder that the rules that have just been adopted require that the health insurance companies start making reports to the department on a 3-year basis. And the first report is due March 15th, 2023. And this is this ask that we have for you to rank, if you will, by your perspective, your rank by importance from your perspective, is really to help us focus our very limited resources. It isn't to say that we won't, we're going to get a report that has a lot of NQTLs in it, all NQTLs in it. But we know that so we just want to be focusing our resources on those that everybody, that the majority of people believe are super important. So that's why we're asking for your input on this question. So again, I don't know, as Lynette said, we're just about out of time. If anybody has, you look at this list and right off the bat which ones how you would rank them, and if you're comfortable saying so, please feel free to speak up or put it in chat. Otherwise, what we may do is send out a document. I think we can do this with, we got to make sure we can do this with the open meetings law stuff, but we could send out a document or an email to everybody with this list and just have you send it back to us. And then we could report on that at the next meeting. If that works within our open meetings laws. Any preliminary reactions to the list?
Hi, this is Vista from Blue Cross. It seems to me that you have definitely some of the top ones on the list. I know when we were looking some time ago, we were consulting people to help us sort of begin to look, outside consultants and things. I remember one consultant really focused in on prior auth and saying that that's really the key to everything. And I'm not sure I agree with that statement, but that was, if that gives you some idea, that it was certainly what they considered to be one of the key NQTLs. The other thing that crosses my mind is that I think there was a federal report to Congress on MHPAC compliance, the 22, it was the 2022 report, but I think it came out earlier in the year, and I think another report is going to be due coming up in October. So by then there should be some findings and conclusions. So some of that may provide guidance as to, where are the problems, and that would certainly, drive the need for, or help focus attention on the problem areas, because that's going to be kind of a nationwide look from the DOL that's been enforcing that at a federal level. So that might be a helpful source.
Good suggestion. Yeah, and by the way, the fact that these are numbered is in no way a reflection of the department's ranking of anything. I just realized that we numbered them. So please don't take any meaning from that. Although, as Vista said, we too have been hearing a lot about the importance of prior authorization. So, and because it's your avenue to care. So if you're having a hard time getting prior authorization, or you can't get as many, prior auth for enough visits, or, the steps to get prior authorization are, vastly different for mental health than they are for medical.
This is Kathy Busby. I'd like the list. We'll go back and check with folks. In particular, I also think the provider networks is what I'm hearing a lot about, but again, I appreciate the list and look forward to speaking further.
And Aaron, it's a good list, and I we could probably spend the rest of the afternoon on it. I think what I'd like to do, I have my thoughts on it, but I'd really like to hear from some others who are dealing with this day in and day out, and ask them too. Because I know there are issues that come up that I would not have suspected, like on the formulary design or step therapy, where in the mental health arena, there's some funky things that go in, and a lot of it's for just people not being aware, surprisingly, thinking that it's one way, but it actually works another. And I think so I would like to ask some folks and get back to you. Is there any timeline that you need to respond?
Well, sooner rather than later, but no, I would say maybe a month from now. By a month from
that's
now.
good. That's plenty. Yeah.
That would be great.
Yeah, that works.
Oh, good. Oh, good. Thank you.
David, I see your hand up. Do you have a comment? I don't know if he can hear me, but I see his hand.
Who had their hand up?
Pardon him? He's one of the committee members that have. Well,
Yeah, it's interesting that different people see this differently. The prior auth, I would have thought while it has been important historically, in managed care, that a lot of people are getting away from prior auth actually, but
Yeah, agree, but I think retrospective reviews are important too.
Yeah.
I think the networks too, depending on what is meant by, if that's probably the broadest use of the term, there are a number of things in there like rates and how rates are set that I know are areas of concern.
Mm-hmm. Yeah, absolutely.
This is Dave Carnahan. I guess the piece I was going to add to it, coming from a hospital provider perspective, is the concurrent reviews. I mean, I can tell you hours that are wasted that insurance companies intentionally put in place so that you're sitting on the phone. And so, and certainly there's nothing like that on the medical side in terms of how concurrent reviews are handled and asking for additional days and things like that. And I don't think it's even necessarily the process, although the process should come in question. It's how it's implemented, and it's implemented to elongate the process and make it more difficult to get the approvals. So certainly something that's very different from the medical side.
So I heard folks specifically call out provider networks, concurrent review, prior auth, and retrospective reviews. I heard very specific comments on those four, the top four, in fact. Although I also heard Dr. Fowles say, and really that formulary and step therapy are of interest too. So maybe we could do this. I don't know if everybody feels like they can capture this list and think about it and then add to it and send it back. We don't have a meeting scheduled for October, but I think the department would really welcome people's input before our November meeting. So we could I'll double check and make sure that it's okay with open meetings laws for us to send all of the members this list by email and have you rank it and then add to it and then send it back to Lynette. Because I think as long as you're not talking to each other, you're just talking to Lynette, I think it's okay. So maybe we can do it by email. We'll
Do you want to do a survey monkey?
I was thinking about that. I was
Yeah.
thinking about SurveyMonkey. Yeah. We can, and we've got SurveyMonkey, so we could send it out to the members that way. That's a great idea. Thank you.
Can I ask, is there any way, and I don't know if this is possible or not, some are really obvious, but as I'm looking at this list, and I too would definitely want to take it back and speak to others internally within our organization, but the provider networks, can someone give me a sense of what we would be looking to achieve with that as it relates to parity? Like, what direction would we be going with some of these? That one and step therapy are two that I just kind of am trying to wrap my head around a little bit more on.
So I can speak to that somewhat. This is Kathy, that often the networks are just not adequate of the different license types. It takes a long time to get in, particularly to certain types of providers. Some of that is rates. So it's a multifaceted problem.
So just kind of globally the difference in, okay, that helps me. I just wasn't sure if there was one thing in particular, or if it was much larger, and grasping that it's the much larger global comparison.
That's the way I see it. I've heard from.
Okay, thank you.
Yeah, I agree with you, Kathy. Yeah.
I think I would add, though, that if there are nuances to, so yes, the adequacy of the provider network adequacy is in the behavioral health space is absolutely probably the top of mind issue for provider networks. But if there are nuances to that, one of the things that we hear from the public about is, well, I looked at the health plans directory and I called every single mental health provider they had, and nobody could see me or nobody would take me for this particular issue, et cetera. So that's kind of a nuance to that. Credentialing might be another issue. Sorry, Lynette, what was that?
I was saying the access to care where they can't get in for 90 days, or it says they're taking new patients, but they're really not.
Right.
I think
Accuracy.
Dr. Fowles?
Yeah, an issue that I know the Psychiatric Association is interested in and has arisen in other states for sure is the issue of how rates are developed and set. On the medical side, it tends to be a lot more objective and facts-based. On the behavioral health side, it's been not so much. And so I think there's a lot more to it than just that, obviously, but in the sake of time, that is an area that there's a lot of attention being focused.
So reimbursement, how reimbursement.
Yeah, reimbursement, how rates are set. Yeah.
Okay.
Which then leads to whether you have an adequate network or enough
Exactly.
timely access to care.
Exactly.
I don't know if this would fall into the same category, but I also think that related to the network providers, there's the issue that the network considers, some of them obviously consider behavioral health providers specialists, and then they set up their deductible plans accordingly. So if I were to go to my primary care to get an antibiotic, I may have a $10 copay. But if I need to go to my behavioral health specialist to get a pill, I'm going to have a $125 deductible payment. And when we're looking at parity and preventative care, by them being allowed to consider behavioral health specialists and charge, different deductible and copays, that is also a barrier to access for these patients.
Nicole, I have a question for you about that. Do you, really naive question. Do you perceive that there are visits to a psychiatrist or a psychologist that are more on par with a visit to your primary care physician? I mean, I could see like,
Yeah.
okay, I just need to make sure that my medications are still, the way that they should be. If I go to my primary care to make sure that I'm, they test my blood and they test this to make sure that everything's still situated. So are there visits to a mental health provider that are on par with a visit to a primary care?
I personally would consider psychiatry that. So while therapy is something you may do, 10 weeks of, or whatever the amount that you need is, and then it would be over, that's a little bit different than primary care. But when you're a person with a mental illness who needs to see a psychiatrist regularly to have your medications prescribed, and they're really, seeing you, maybe they're taking some blood, and then they're prescribing your regular daily ongoing use medication, I don't understand why that's any different than going for your diabetes medication. I mean, it's the provider you have to see to get this medicine. So that to me is not a specialist. That's part of your routine care.
Good point.
That's a good point. I wonder how that looks in an integrated space where the provider and the psychiatrist are in the same building.
I don't know, but I can tell you it's different insurance to insurance.
Sure.
Like
Yeah.
one commercial company will charge the same for the patient as a primary care copay, where another says, no, you're seeing a specialist, so now you have to pay the specialist fee.
Is there a difference in the billing codes or in the CPT codes for a patient that comes in for an acute issue versus a maintenance issue?
Yes, there is. So there's your regular office visit, and then there's like urgent visits, which is a different code. And I don't know those off my head, but I do know they're
I don't need, I don't, yeah. But I just wondered if there was, if it's relative, if it would be identifiable to the insurer, and I imagine it would be, what kind of visit the patient came in for, and if there was, could be a mechanism for them to determine, well, this is basically a primary care visit versus something else. So just thinking out loud.
There is, and even there's nuance in the coding where like it's the same code except the last digit, and that last digit indicates the severity of care the patient is needing. And so, just thinking 213, 214, and 215. A 213 is a standard visit. They're literally just coming and getting their medicines. They should not be paying deductible rates for that.
Interesting.
Yeah.
Very helpful.
Yeah. It gets pretty deep from an issue of vows, subsequent visits, the intensity of services. Yeah, so fun discussion.
Yeah, really. But those are good points.
Yeah, very, very interesting. Okay.
So if we're okay with public meeting law, we'll send out either a Survey Monkey or
an email
spreadsheet with the email where you can log and talk to other people in your departments and agencies to kind of help us rank and prioritize which NQTL we should tackle first. And have about a month to do that. And also our next meeting is slated close to Thanksgiving. And I know that everyone loves to work through Thanksgiving, but some of us like to take Thanksgiving off. So we wanted to move the meeting up to the 4th if everyone is okay with that. So we're not getting into holiday vacation time and things like that. Any objections? The original date was November the 18th, which is the week before Thanksgiving. Off early, which is, we need to also do our self-care, so that's great. Is November 4th okay with the committee?
Yeah.
Yes.
Excellent.
Yes.
I will send an updated calendar invite so we know the meeting has changed for that. Okay, we've kept you like 10 minutes over. Any last comments for the good of the land?
Any topics for next meeting that anybody would like to cover? Anything, I mean, we'll probably pull up this last topic that we talked about again, but if there's anything else that you'd like to talk about further from what we heard today or any other topics you want to discuss, we're always open to hearing suggestions. You can always email us, email Lynette.
I thank everyone for the robust discussion. I think all the presenters for presenting today has been really good. So.
Yeah, good meeting, Lynette. Thank you.
You're welcome. Have
Yeah,
a
thank you.
fantastic weekend.
Thank you. Bye.
All right. Thank you.
Bye.
Take care.
Bye.